Welcome, dear colleagues and students, to this 130th webinar of ours, Critical Case Sunday webinars. And today the topic is extremely important, acute liver failure. And we have a very distinguished speaker today, Professor Shalimar. He is Professor of Gastroenterology and Hepatology at All India Institute of Medical Sciences, New Delhi. And to his credit, last year he was ranked among the top 2 percentile of clinician scientists in the country, which is a very distinguished achievement. And he has more than 100 publications, and liver disease, different types of liver disease are his area of interest for research. So I think we are in for a very wonderful talk and much delightful learning. So over to you, Shalimar sir.
Thank you, Dr. Tapesh, for the kind introduction. So, can I start sharing my slides?
Yes, 1 minute. Okay, now you can share.
Okay, I'll just start sharing the slides. So, is my slides visible?
Yes, sir.
Okay, good. So, we're going to talk today on a topic which is acute liver failure. This disease is very uncommon. It's not something which you see routinely in your clinical practice, but then it is very important to know about this disease because this is associated with a very high mortality, and a timely intervention can save the life of your patient. So, this is the outline which I'm going to talk about in the next 45 minutes or so. I'm going to take you through the physiology of the liver. What does the liver do, and how and what are the symptoms which occur when the liver is affected during the acute liver failure phase. I'm also going to talk to you about the definition of acute liver failure, how you need to evaluate such patients, which investigations are needed. Then in the end, I'm going to take you through the management strategies which are available with us for managing this disease. In that, I'll talk to you about the medical management. I'll talk to you about the liver assist devices, upcoming modalities of therapy which have shown some promising results, including plasma exchange, and the definitive treatment of acute liver failure, which is the liver transplantation. So if you look at the physiological functions of liver does multiple functions, and they help in maintaining homeostasis. If you look at, it helps you in the metabolism, it helps in the storage of vitamins, minerals, and also as a horsepower in the sense as it produces sugar, which helps you to have energy and do the activities. Liver produces proteins, and common proteins, what we know is albumin and other proteins are produced by the liver. In addition, liver also does an important function of synthesis of bile, helps in digestion of fat, and absorption of vitamins, including A, D, E, and K. It also produces lots of coagulation factors, which help in the coagulation cascade. In addition, other proteins, including opsonic proteins and complements, are produced. And it also detoxifies drugs and also takes care of ammonia, which is converted into urea and excreted out of the body. So now this is what we know about the physiological function. So what happens then when we have liver failure? So whatever functions which I talked about in the last slides, when there is liver failure, these functions do not happen, and then the clinical manifestations in form of dyselectrolytemias, hypoglycemia, as liver is not producing sugar which is needed. The albumin which is synthesized by the liver goes down. There is deficiency of vitamins. In the coagulation cascade, when the coagulation factors are not produced, it leads to prolongation of the INR, which can be measured in the lab and which helps us in knowing about how the synthetic functions in the coagulation cascade are affected in a patient with liver failure. In addition, when the opsonic proteins and complement are not produced, which help in fighting infection, an individual with acute liver failure or any liver failure is predisposed to have more infection. And it is important to know about this because infection is a major killer in these patients. In addition, we talked about ammonia detoxification, and ammonia, when it is not metabolized in the liver, leads to higher levels of hyperammonemia. And I'm going to take you off about and talk to you about in the next few slides about all these functions and how we are going to manage such patients. Before I talk to you about more details about the clinical manifestation, let's get our basics about what are we really talking in terms of what is this disease entity, because liver failure is a common umbrella term which you'll hear, and then there are multiple implications of this term. So let's talk about the semantics. First, what is severe acute liver injury? So acute, as the word itself tells you, there is severe injury to the liver. And how does it clinically manifest? Clinically manifestation would be is jaundice and prolongation of INR. These patients usually recur, but some of them may progress to liver, to ALF. ALF is defined, remember that you need to have hepatic encephalopathy. Without hepatic encephalopathy, it's not ALF. It is then is a severe acute liver injury. So in addition to hepatic encephalopathy, you got jaundice and an INR more than 1.5. Usually this syndrome occurs over a few hours to days. And in our Indian continent, subcontinent, we see most of our patients presenting within 28 days. In contrast, when you start reading Western literature, they say the duration may go up to 6 months. Then comes another entity which is known as subacute liver failure. In this entity, there is jaundice followed by ascites, usually occurring usually occurring after 4 weeks. So over here, when we talked about acute liver failure, it is occurring within 28 days, that is 4 weeks. So this entity presents to you with jaundice followed by ascites, usually after 4 weeks or so. And the INR abnormalities are late and it is associated with high mortality over 3 months. This entity was something which we used to describe in the late 1980s and 90s, but of late this term is not commonly used. So there is a new entity which has come up, which is acute on chronic liver failure. So over here, in contrast to acute liver failure, we are talking about a disease state in which there is already a presence of cirrhosis. So any deterioration which occurs on an underlying liver disease is called as acute on chronic liver failure. This syndrome, in addition, may also have multi-organ failures and is associated with high mortality. So over here, in the first two, we are talking about underlying normal liver. In the acute and chronic liver failure, we're talking about an underlying cirrhosis, and then superimposed on that, an acute insult occurs, and this patient gets decompensation with jaundice, ascites. This is the term what we call as acute and chronic liver failure. So again, to reiterate, acute liver failure is defined as occurrence of encephalopathy within 4 weeks of onset of an acute hepatic illness in an individual without underlying pre-existing liver disease. Because if there is an underlying pre-existing liver disease, you're going to label this patient as acute on chronic liver failure. So the components include encephalopathy, coagulopathy, and most importantly, absence of an underlying pre-existing liver disease. So with this in background, we'll move forward. So as we know what is ALF, now look at what are the causes of acute liver failure. Broadly, when we talk about causes of acute liver failure, they can be categorized into infections. Infections could be viral, most commonly what we see in our country, and we'll talk about them. So the hepatotopic viruses includes hepatitis A, B, C, D, and E. The other viruses include CMV, cytomegalovirus, herpes simplex virus, also known as HSV. In addition, metabolic diseases, which includes Wilson's disease, galactosemia, drugs, and toxins, and commonly the drugs which are known to cause acute liver failure, and what we see in our country includes anti-tubercular drugs. The data from the West suggests paracetamol and other drugs, including anti-epileptics, may be responsible for development of acute liver failure. In addition, there are other toxins in what we know as Amanita phthalates, which is there in mushroom poisoning, can also present as patients with acute liver failure. In addition, other entities which can present as acute liver failure includes, especially in pregnancy, we'll talk about them, autoimmune hepatitis, acute Budd-Chiari syndrome, and shock liver. So these are but commonly what you're going to see is these hepatotropic infections with hepatitis viruses. So let's look at what is the etiologies of acute liver failure in our part of the subcontinent. So this is what you're going to see in your clinical practice. So this is the data which stands for almost like 30 years. That's almost like 3 decades of data collected at our hospital. And what we found is that most common includes a group which is cryptogenic, and the next most common is hepatitis E viruses. this presentation of cryptogenic is essentially similar to what we see as the clinical presentation as in viral hepatitis. So effectively, in 1/3 of patients, the etiology of viral hepatitis in adults, that is the acute liver failure which we're talking about, is hepatitis E virus. 7% would constitute is constituted by drugs in form of anti-tubercular therapy. And hepatitis A, as what we all know, is commonly a disease of the children. And we see hepatitis A in adults in a very small number of patients. Okay, let's look at how the etiologies of ALF differentiate, or say how they are different between the Indian subcontinent versus the West. So let's look at over here in the data published, or what's published from the West, that includes the Europe and the Americas. What we see is that paracetamol constitutes the majority of cases of acute liver failure, and almost like more than 50% of cases of ALF are due to paracetamol. In contrast, in India, it is the viruses, and drugs constitute only just 6 to 7%, as I have highlighted. In addition, other causes which have been reported more commonly in the West includes the metabolic causes, and a fraction of patients would have indeterminate, or what is also known as cryptogenic, or is constitutes almost like 20% of patients of acute liver failure in the West. Okay. But when you are seeing this patient, which we talked about, is a syndrome, because you're going to have a patient who has a syndrome. He's not going to come and tell you what is my diagnosis. Here you have got a patient who's got altered sensorium, who's running fever and has got jaundice. So you need to start thinking about, does my patient have acute liver failure? Yes, it's a syndrome. But then there could be other mimics, which could be the possible reason for the clinical presentation. And these differential diagnoses over here include bacterial sepsis. Tropical infections, which are commonly seen and which we also see these days commonly, is dengue. Is very commonly presenting with severe presentation, and the patient may have a similar presentation as acute liver failure. In addition, malaria, enteric fever, and leptospira can also have similar presentation. You also need to keep in mind possibility of an underlying cholangitis and an underlying chronic liver disease, as I mentioned, as any superimposed injury or infection over an underlying in a cirrhotic patient can also present you with similar clinical syndrome. In addition, altered sensorium and jaundice may also be a clinical manifestation of patients with meningitis and encephalitis. So we need to keep in mind and start thinking about and ruling out all these possible differential diagnoses before you finally make a diagnosis of acute liver failure in your patient. So now again, coming back to the same figure which I showed you, what are the functions of liver? And let's go one by one about how you're going to investigate and manage these patients. So I'm going to take you through these symptoms which I have shown. So what you're going to investigate and send when you have this patient is to send the routine investigations, including the hemogram, liver function test, the INR. So that helps you in assessing the coagulation cascade and also gives you an idea regarding the presence of infection. Over here, in addition, you need to also send is the cultures. You need to get his blood sugars done. So we talked about that these patients have hypoglycemia as the liver is low on the glycogen reserves. So you need to regularly monitor blood sugars in these patients and see that, most importantly, your patient should not go into hypoglycemia. In addition, you're going to also send the renal function test. Renal function tests are uncommonly involved in the viral etiologies of acute liver failure. But then when there are drugs involved, especially paracetamol, that's been described from West, that kidney injury is quite commonly seen in that group of patients with acute liver failure. You also need to do an ultrasound in such patients to see that is there a presence of an underlying chronic liver disease? Is there a presence of ascites? And there are any other complications? As we talked about, the differential diagnosis includes cholangitis. You also need to look at what is the status of gallbladder, how's your bile duct, is there presence of splenomegaly, is there presence of ascites, how is the portal vein, is my patient having an underlying chronic liver disease or not? So we've sent all these investigations. Now comes in, what is the etiology of acute liver failure in my patient? So we talked about viral infections are common apart from drugs. So you're going to take a good history from the patient's relative, asking him, was he consuming any kind of drugs? Does he have an underlying any kind of condition for which he's on any known drugs which can cause injury to the liver. In addition, you're going to send a battery of investigations for the workup that includes the viral etiologies like hepatitis A virus, hepatitis B, C, D virus. You're going to work up for Wilson's disease. You're also going to send samples for autoimmune liver disease. So now we have sent all these investigations. Now coming to how we are going to manage this patient. Now the clinical manifestations we talked about is hypoglycemia. So it's very important that you need to do regular sugar monitorings and take care of the hypoglycemia of these patients. Hypoglycemia may be seen in as commonly as almost like half of your patients. And it's very important because, as you all know, that hypoglycemia can lead to an alteration in the mental status, and you may find it difficult to interpret whether the patient has hepatic encephalopathy or hypoglycemia as the reason for the altered mentation in these patients. And we all know that how rapidly the sensorium improves by correction of hypoglycemia. So it's important to take care of this entity in this patient, which is very common. So you regularly monitor the blood sugars at 2 to 3 hour interval. So if the blood sugar is less than 60, you need to give them a dextrose solution. You can give them as 50%, 50 to 100 ml dextrose to be administered, and you can repeat it as frequently as required. There usually would be a maintenance drip which is given to maintain the sugars in a normal range. Now, how about hyperglycemia? Hyperglycemia is another problem. So you need to also take care of that when the sugars are very high. You need to control the sugars. And we know that in those patients who got an underlying diabetes, they have more severe complications in patients with acute viral hepatitis. So it's important in such patients or in any critically sick patients. And you know that in any critically sick patients, you're going to take care of both the extremes in terms of both hypo and hyperglycemia. Now comes then there could be other abnormalities which we talked about in terms of other dyselectrolytemia, which in any critical patient is there and you need to take care of. Especially when we talk about acute liver failure, it is very important to know that what is the level of phosphorus. Now, phosphorus is a very important predictor, which the levels can help you in predicting the outcome in patients with acute liver failure. Interestingly, over here is that those patients who got low phosphorus levels have a better prognosis. All suggesting is that this suggests that there is liver regeneration going on, and then the ATP is being produced, the phosphate levels are down. That suggests the liver is regenerating, and then hence these patients have more spontaneous recovery. So it's very important to look at the phosphorus levels and take a call for correction of phosphorus as required. In addition, you need to also take care of the other dyselectrolytemias, which we talked about. If your patient has, for any critical disease, the principles of management remain the same for like any other critical patient. So you're going to take care of there is in presence of any hypocalcemia, hypomagnesemia, hypokalemia, or hyponatremia. You need to take care of that. Now, coming to the more important point, in acute liver failure patients, we know that they have got altered sensorium and increased intracranial pressures. Now, what has been shown is that as the sodium goes up, the ICP goes down. So over here, this is a beautiful study done almost like 3 decades back, shows that as the sodium levels are going up on the x-axis, the y-axis, if you see the ICP goes down. So keeping sodium slightly on the higher side helps in improving the outcome of a patient with acute liver failure. So when we are managing, we try to keep the sodium somewhere between, say, 145 to 155. That helps. And slightly on the higher side, sodium is good for such patients. Now comes the other important point which we raised is that patients with acute liver failure also have decreased production of proteins, including opsonins, proteins, and complements. So this predisposes also these patients to infections. Infections are very common in these patients. So this study showed that almost half of the patients who present with acute liver failure, those who got an acute liver failure, will have infection at any point of time. Now, when we look at these infections over here, which is any time point of infections, almost like half of them are going to develop infections at admission or within 48 hours of presentation to the hospital. And in the rest of them, the infection develops after 48 hours. So you got a patient who's sick, who the liver is not working. You already put in so much of catheters, and when the patient is an altered sensorium, you got so much of IV lines. You would have a urinary catheter, and you better know than me that catheters predispose a patient to more infections. So these patients are at risk of catching infections, and that's the point where you need to think about, in my patient, I need to treat the infection quickly. If you delay management of infection, your patient may have severe complications and may die of infection and sepsis. And infection, along with raised intracranial tension, is the most common causes of death in patients with acute liver failure. So if you look at infections, is it what we are talking about is only the bacterial infections? Yes, predominantly 80 to 90% of infections, what we see in acute liver failure would be bacterial. And out of these bacterial infections, the organisms which you're going to grow are Acinetobacter, Klebsiella, and E. coli and Pseudomonas are the most common organisms which we see in our hospital. But then this kind of profile varies from an institution to institution and what kind of setting you're working. So most important point to remember and take home message from this slide is you need to think about infections. You need to start sending samples for these patients. You need to be aggressive and try to find something on the cultures, because once you've started these patients on antibiotic, you need to change the antibiotics quickly depending upon the bug which is growing and which is causing sepsis. And the sites of infection we talk about when in these patients include the respiratory tract being the most common, followed by you may have bacteremia, then urine infections would be seen in these patients. Fungus is also something which you need to be fungi, you need to think about, including Aspergillus, Candida, which could be commonly seen as infections, and you need to manage these with antifungals as required. Okay, so you are managing these patients now and you got infection, you've treated. Okay, so let's, and what you need to do is we talked about the same things, is that you're going to send samples for cultures. We as a policy give both prophylactic antibiotics and antifungals. But then these decisions of giving antibiotics to such patients are more of a day-to-day, something like you need to individualize use of antibiotics in these patients and see how your patient is doing. Is he getting new signs of SIRS? Is his is he manifesting any new change in his symptoms? And that's how you need to take a call. And if you've given only antibiotics, patient is not responding, you start thinking about, does my patient have a fungal infection, and use start or add on antifungals to this. So this is our individual hospital policy, and this policy of giving antifungal varies from center to center. You need to take a call regarding the choice of antibiotics and the choice of antifungals as per the center in which you are working. But in our center, we give a broad spectrum, one antibiotic, one antibiotic for gram-positive, and one antifungal. And over these patients also have these catheters and IV lines. And most important to remember is, if your culture shows you any new bug, change antibiotics that it's on that day itself. Don't wait, because a infection which is untreated, which is resistant to the antibiotics you're going to give, is going to cause a severe complication in your patient. And once that severe patient becomes more sick, it is very difficult to get them out of this infections. Okay, now let's coming to the next important thing about the coagulation cascade. We talked about that in patients with acute liver failure, a lot of abnormalities in the coagulation cascade. Now you're seeing this patient who's got an INR of 3. You're very worried. What do I do with his INR? Do I give him prophylactic fresh frozen plasma to correct his INR? So it is not recommended to give any kind of blood product for correction of the INR in such patients. Even when you are trying to put in any kind of catheters, it is not recommended. The reason behind this is that the people have shown that in patients with acute liver failure, when tests for coagulation cascades are done in form of thromboelastogram, these patients are not actually hypocoagulable, but these are hypercoagulable. So prophylactic giving of transfusions also leads to more complications in these patients. And we all know that giving blood products leads to increase in the intracranial tension. So you cause more harm by giving prophylactic blood products. So if a patient is bleeding, then you need to give, and at that time when he's bleeding, thromboelastography may be a good choice to decide what kind of blood products you're going to give to your patient. In addition, as critical care specialist, you're going to manage any patient and give him supplementation with vitamins. That is what you need to do in these patients. And vitamin K supplementation is not required and has not proved to be of much benefit, specifically giving them. But as you're giving it any critical care patient, you can take a call for supplementing vitamins as required. When we talk about trace elements, yes, there are some benefits of trace elements, especially in terms of zinc. Zinc has been shown to have some antiviral activity. And we know that other trace elements, including copper, selenium, manganese, as you do in any critically ill patients, you need to take a call for supplementation for these. And though there is no data to suggest any benefit, but then there's no data to suggest also harm. So as you're going to supplement in any critically ill patient, you continue supplementation for these patients also. Now comes the important thing which we talked about. When the liver is not functioning, the ammonia levels go up, and that is what we are all worried, is that this patient has hyperammonemia. So what is this effect of ammonia in terms of outcomes in patients with acute liver failure? So what has been shown is that ammonia has been shown to be of prognostic significance, and higher levels of ammonia predict outcomes. When we talk about predict outcomes, one, they predict survival. Two, they also predict is development of complications in terms of other organ failures, like those patients who got higher levels of ammonia have higher mortality, have higher complications in terms of renal failure, they require more ventilation, they get more cerebral edema, they've got higher grades of encephalopathy, and they also get seizures. So ammonia has lots of problems. So we need to now is think about ways how we can get the ammonia down in a patient with acute liver failure, with the hope that getting ammonia down improves the outcome of such pain. In addition, what has been seen from the data is that those patients who persist to have higher levels of ammonia, that means if you look at an individual who's on day 1, day 2, day 3, the ammonia levels are persisting in the range of say 140. Among these patients, the hepatic encephalopathy doesn't improve. In contrast, in those patients, those whose ammonia levels come down, the encephalopathy improves. And it's seen in both in those patients who got early HE at admission and those who got advanced HE at admission, thereby again suggesting is that we need to work on targets, how we can get the ammonia down and then help improve the outcome in such patients. We know that patients with ALF are catabolic. Now you've got a patient who's got signs of SIRS, he's having a lot of hepatic necrosis, he's got infections, so there's a lot of catabolism going on. So the next important point or the question comes in, how am I going to feed this patient? And it is a catabolic state, you're having a lot of the energy requirement has gone up, you need to think about how am I going to feed him. Other concerns come in, such patients will have other complications. Like, say a patient has got renal failure, you need to then is keep that point in mind that you cannot give him a lot of fluids. The other thing is, when such a patient is there, how are you going to feed him? That's the next question which comes to your mind is, do I put in a Riles tube in it? Do I start feeding him with TPN? What I'm going to do in this patient? So the concerns with putting in a Riles tube sometimes is that also increases the intracranial pressure. So whenever you do any kind of stimulation to a patient with acute liver failure, there's a chance that he may start decerebrating and he may have more problems. And then there's also a chance that your injury, there might be some injury in the nasal tract when you're putting in a Riles tube and patient resisting, and there may be some amount of bleeding. So you need to keep those in mind. And if you're trying to put in a Riles tube, the patient needs to be a little sedated, and you need to put in very gently in such patients without overstimulating to cause him more harm. Now, once you have thought of starting feeds, then we start with feeds in the form of calories, in the form of 20 to 25 kilocalories per kg per day, and then you're looking at proteins. So there is no evidence to suggest that you should restrict proteins in such patients. Like you're going to treat in any other individual, you're going to give such patients is also proteins. Proteins are very important. Over here, we're talking about a patient who's got catabolic, and who's losing a lot of or consuming a lot of energy, you need to supplement. Well, our usual concerns are, do we give him restrict calories, restrict protein? So no, we don't need to restrict calories and proteins. We need to give them. And enteral nutrition is better. But more important is, you need to keep in mind is the amount of fluids which you are going to give, and that should not lead to more fluid overload in such patients. So you need to tailor made a diet chart for such patients. And then, because they are in altered sensorium, they're not going to eat orally. So they would either be on, say, who would be in grade, or say depending on encephalopathy, or they would be on ventilator. So you need to tailor made the calories as per the individual patient and monitor the urine output and take a call how much amount of calories and proteins and total volume you're going to get. Now comes is, we're going to use, as we talked about, the enteral route is preferred, but then NG has some issues. And yes, in case you're not able to give enteral feeds, then parenteral nutrition always is on the cards, and then you can take a call of starting. The other question comes in, do I give him lipids or not? Yes, lipids are safe, so there is no issues in giving lipids to such patients. And if there are contraindications for enteral feeding, definitely you're going to take a call for start off the parenteral nutrition in such patients. Now, there is another question comes in. There are so many other commercial supplements available. Do I use hospital-based? Do I use is commercial feed? So that all depends on what setting you're using. You can still the time they're not causing any new infection. The preparation is clean and is sterile. So you can use either hospital-based feeds or a commercial-based feeds, and you take into account that you're able to give that much amount of calories which you have planned in any critically ill patients, same as what you're going to do in these patients with acute liver. Now comes is, there is other commercial preparations which are known as branched chain amino acids, and those have been shown. There is some data to suggest some benefit, but then there is no strong convincing data to suggest is that giving these branched chain amino acids is going to improve the outcomes. But then you need to take an individual call. If available, then these can be given in patients with liver disease and may have some benefit. But we need more data regarding the routine use of these commercial separations. The other thing is, you need to also understand that these are expensive and add to the cost of managing the patient. Okay. From now here, we move on to organ specific complications. So we talked about is, what we see is that another complication, which is cerebral edema. Cerebral edema is common in patients with acute liver failures, and across etiologies, it has been seen that almost 50% of patients with acute liver failure are going to have cerebral edema. So that's a major problem in these patients. And what I talked to you initially is that presence of cerebral edema and presence of infection, these are the two things which are going to kill your patient. So you need to treat, you need to diagnose, you need to manage such patients early. So let's coming to the intracranial pressures. So when a patient who has a low grade encephalopathy, you can just monitor him clinically and see how things are. But when the sensorium worsens, so like a person who's in grade 3, grade 4, particularly in grade 4, you need to think about the patient may need airway protection, and for that, you may need to electively intubate such. So when you're intubating such patients, you're going to stimulate a lot of, when you start putting the laryngoscope, you're going to stimulate the patient, and the patient may have may even go into deceleration. So it's better to sedate such patients, and propofol has been shown to be a good sedative, and propofol is also a reduction in the increased pressures. So propofol is the choice of the sedation which should be used in such patients when you're planning an intubation. So now your patient is intubated, or say the patient, you plan to check what is his intracranial pressures. As we're talking about, this is an important prognostic marker which influences the outcome of such patients. So how can you non-invasively look at the intracranial pressure? So you can do is an optic nerve disc diameter, which you can repeat frequently. You do it in, say, it depends upon the condition of the patient, but it can be easily done 4 to 6 hourly to see how are the pressures changing. If the pressure is changing, you need to take a call for the management. So non-invasively, apart from that, is the carotid artery Doppler. Both of these modalities don't really correlate very great with the what is the intracranial pressures, but then non-invasively, these are good surrogate and then help you in knowing what is happening in your patient. Apart from that, you can have a look at the clinical parameters. And the other question comes in, how do I, the best way to monitor is to do is invasive intracranial monitoring. Now, invasive intracranial monitoring involves putting in bolts. Now, so bolts are associated with, so in a patient over here, you are having is coagulopathy. Superimpose that on which you want to think about putting in bolts through the skin to measure the pressures. Then when you're going to put in bolts, they increase the risk of bleeding, they increase the risk of infection. So most centers these days do not use bolts for measuring the intracranial pressure. So this is usually monitored non-invasively and use of clinical parameters. The next question comes in. Now your patient has altered sensorium, he's intubated, do you plan to give him prophylactic anti-epileptics? Because we talked about seizure are also common in these patients. But there's data to suggest that prophylactic use of anti-epileptics such as phenytoin has not been shown to be of use in patients with acute liver failure. In case your patient has seizures, then levetiracetam is a safe anti-epileptic, does not cause hepatotoxicity. This is the anti-epileptic of choice which can be used in your patients for managing a seizure if there. And plus, you need to think about what are the causes of seizure in this patient and start treating those causes. In addition, there are a lot of other drugs which you know in liver disease which have been used in the management of hepatic encephalopathy. And usually in chronic liver disease, we use drugs like non-absorbable antibiotics in form of rifaximin, laxatives like lactulose, and drugs like L-ornithine L-aspartate, also known as Lula, which is available both as oral and parenteral route. These have been shown to be of benefit in patients with chronic liver disease, to those who got an underlying cirrhosis, but then there is no definitive data available for benefit of use in patients with acute liver failure. But on case-to-case basis, you can take a call for using these drugs. And the other thing is what you need to maintain is the serum sodium in these patients, which we talked about is going to be maintained between 145 to 150, 155. So a little higher sodium helps in reducing the intracranial pressure. When there are surges of intracranial pressures, then you can use is mannitol, hypertonic saline boluses can be used. But important to remember is that patients, when you start using mannitol, then you also need to monitor the serum osmolality. The other important question comes in is the use of hypothermia. So am I going to get this patient to a low temperature than the normal temperature of 37 degrees? So this data comes from a multicentric retrospective analysis from the United States, and this showed very clearly that there is no benefit of hypothermia in patients with acute liver failure, both in the paracetamol group and in the non-paracetamol group. So it is not recommended to reduce the temperature of your patient with the hope that that is going to improve the outcome of your patient. Now comes the important issues like renal failure. AKIs are common, and we talked about that drug-induced acute liver failure patients have more AKI, kidney problems compared to those patients who got viral hepatitis related AKIs. Now, when you got a patient who's got AKI, then your question importantly comes in, does my patient need any kind of renal replacement therapy? So the indications for renal replacement therapy remain same across all critically ill patients. Is you need to take a call for renal replacement therapy when there is fluid overload, there is presence of hyperkalemia, metabolic acidosis, and uremia. So these are same across all patients. No specific preference in terms of in patients, no specific other indications. But then there is a benefit of using CRRT over intermittent hemodialysis, as this is better tolerated and also reduces the intracranial pressure. So the use of CRRT definitely is beneficial in patients with acute liver failure. And the type of anticoagulation also have been shown to have some differences because you may use little less of heparin over here or heparin-free renal replacement therapy. The other benefit which we are looking at with CRRT in patients with acute liver failure, and which is also sometimes considered as an indication in specific case-to-case basis, is whether this use of CRRT helps in reducing the ammonia levels. So, and we know that reducing ammonia levels are may be associated with improvement in the outcome. And then this study showed that use of renal replacement therapy led to a significant reduction in the ammonia levels compared to those patients who are not treated with the renal replacement therapy. So that becomes another extra indication for subjecting these patients to renal replacement therapy apart from the standard indications for dialysis. Now comes the respiratory issues. When we talk about which are specific to patients with acute liver failure, we talked about the use of propofol as a sedative. So when you're planning ventilation, use propofol. And then the tidal volumes remain between 6 to 8, and then minimum PEEP. And then these need to be individualized for a particular patient, and decisions need to be taken upon depending on what kind of, does a patient have a chest infection? Does he have associated ARDS? Does he have associated other underlying lung diseases? And then you need to take a call for the ventilatory setting in such way. There is another concept of, do I prophylactically hyperventilate my patient? So there is no benefit of using prophylactic hyperventilation, and because when it's, so you maintain your target of PCO2 between say 30 to 40 as what you're going to use in your routine patients as any critically ill patient. And you need to avoid both hypocarbia and hypercarbia, because both of them are associated with major problems. So if you hyperventilate too much, the PCO2 goes down, the cerebral blood perfusion also goes down. So that's going to cause harm to your patients. And data suggests no real benefit of doing prophylactic hyperventilation. Next comes is when your patient, your staff, or you do considering suctioning. The problem is that when you start putting in the catheters too much into the endotracheal tubes, and they also cause bit of stimulation, and then can lead to raised intracranial pressure. So that is something which we need to avoid. We need to be very careful for that. Raised ICT, which we talked about, is a problem. It kills patients. We need to manage such patients. Now comes the role of ECMO. ECMO, you know, you use it more frequently than and have more experience than me. Is that it could be used in specific instances when you're looking at refractory hypoxemia or a bridge to transplant. Maintain the ventilations you can in specific situations. Consider when a patient is critically sick, and then you don't want to buy more time, and then you need to think about subjecting these patients to ECMO. Specifically to the cardiovascular issues we talked about, then you need to consider replacement of crystalloids as required. Noradrenaline is a drug of choice for if there is any as an inotrope. Maintain MAPs between say somewhere around 60 to 75. A higher MAP is not what we are looking at. Is going to it's more detrimental. And use of steroids have not really been shown to be of improvement in the mortality, but then yes, as you use in the sepsis indication, you can consider use of steroids in those doses in specific instances as required. So, but then use of steroids in patients with acute liver failure has been shown to be more detrimental in the long run, as it predisposes them to more infections, particularly fungal infections. So, routine use of corticosteroids is not recommended in patients with acute liver failure. Now comes the important question. You got a patient in your ICU, you are seeing him. How am I going to prognosticate? When I'm going to refer to this patient for liver transplantation. So you start with medical management, as we talked about. Your patient is in the ICU, you've given him ventilation, you're taking care of ICT, intracranial pressures, you're taking care of his electrolytes, infections you are managing. So now there is a chance, is he going to improve? Is he going to worsen? That's how you're going to come up now is use of prognostic models, which we're going to talk in the next few slides, and consider liver transplantation at the right time, because that may help in improving the outcome of your patient. So when to list? So every patient who walks in with a diagnosis, or who's admitted to you with a diagnosis of acute liver failure, you need to put him onto the transplant. You need to start counseling for transplant on the day one. And because if you delay the transplantation, the outcomes would be very poor. And if you consider a patient for transplantation early, you're denying the chance that his liver is going to regenerate on its own. And we've now shown that gradually, with improvement of medical care, there is an improvement in the regeneration. So the number of transplants which would be needed in such patients is now, or say the deaths happening without transplantation have reduced with time. So, what is a prognostic score? So, prognostic score is something which helps you in predicting the outcome in that particular patient. It needs to be very simple, easy to do, objective, and can be measured regularly. It is reproducible and has a high sensitivity, specificity, PPV and NPV. Unfortunately, we do not have any good prognostic score in terms of that, which gives you 100% sensitivity, specificity, and PPV and NPV values. So let's look at what are the prognostics. Among them, the commonly used, what we know of, is the King's College criteria. It's for more for transplantation, looking at those patients who are going to die. So these are the parameters which includes is a prothrombin time more than 100, or any three of these. That includes age, etiology, the ictus to encephalopathy interval more than 7 days, PT more than 50 seconds, bilirubin more than 17.5. So there are concerns with the use of this score, which I'm going to talk to you in the next slide. Then, so this is for non-paracetamol. So this is for the patients who got. So let me just yeah. So this is for non-paracetamol, and this is for the paracetamol group. So there are slight differences which I just wanted to show over here. And these are the parameters are very different. So especially which I wanted your attention on is the non-paracetamol group, because we don't see paracetamol in India. You're going to have the non-paracetamol use of this King's College criteria. And there are issues like most of our patients, we see in acute liver failure would be between 10 to 40 years of age. So this parameter doesn't stand true. When we talk about etiologies, unfortunately, we don't see halothane or idiosyncratic, we say non-A, non-B. We see a distinct group of what I talked to about is the cryptogenic or the non-A, non-E. The IE interval in our patients is usually less than 7 seconds. So unfortunately, the top three criteria don't fit to our patients. So this use of this prognostic model in our setup is not of much use to us. And paracetamol, unfortunately, we don't see paracetamol. So then again, this model is would rarely be used in a patient with paracetamol poisoning who is more commonly seen in the West. So these have been derived and validated in the cohort in which they were developed. But when we start looking at their validation, they don't do really well in other settings. So this is what I wanted to highlight to you is that in the Indian context, it is predominantly the viral. The derivation cohort of this model was predominantly the paracetamol. So there are issues with the use of these models in the Indian context. And this is what I highlighted to you is that our group is predominantly non-paracetamol. We don't see paracetamol in India, and there are issues with the use of these variables, which I highlighted in the previous slide. So we've got a new model which has been developed specifically in the Indian patients, which is the ALF early dynamic model, which is very simple to use. It just has four parameters, which includes is one is a clinical, three are the lab based. You look at the hepatic encephalopathy, and you monitor over 3 days. So that means you're doing it dynamically. You do it daily and see how much is this change happening. If the change is towards the score increases, that means your outcome's really going to be bad. And we're going to talk about the outcome in the next slide. Encephalopathy more than grade 2 gives you a score of 2. INR increased above 5 gives you a score of 1. Ammonia above 123, score of 2. And Bill above 15 gives you a score of 1. So just add them up. Total score 6. And see over here, as the score goes up, the mortality. So the death rates are very high. So higher the Alfred score, higher is your mortality. So you can do it daily. If your Alfred score is improving, that means your patient is getting better. If it is worsening, that means there is a chance of mortality in your patient. And when Alfred is compared to scores like the King's College criteria and the MELD score, which we use in the liver disease, the Alfred score has been shown to be of higher diagnostic accuracy. So this is the score which we need to look at in our population and see how it can help in prognosticating our patients and also taking calls for doing transplantation in these group of patients. Coming back to that King's College, actually in the non-paracetamol group, when it has been looked at multiple studies, look at the sensitivity is just even less than 0.7. So it doesn't do that well. Specificity is fairly okay as 0.82. So there are issues with the use of King's College criteria. Now come to some specific management that includes the N-acetylcysteine. So there is data to suggest the use of N-acetylcysteine in these doses should be used routinely in patients with acute liver failure. But then this has the best outcome in those patients who got low grades of HE. And then now this N-acetylcysteine is the standard of care for use in all patients with acute liver failure. Now, next comes the other newer options in terms of plasma exchange, which is plasmapheresis, which removes the plasma from the body and then you give us fresh plasma. And this has been shown to have some improvement in the coagulation factors, albumin, and then also improves HE. But then it just is removes all kinds of substances, so it's not very specific. And then it requires large volume of plasma, which needs to be given. And so there is one this randomized control trial which showed done from the a multicentric study from Europe showed that the use of high volume plasma exchange compared to standard medical therapy has been associated with improvement in the outcome. But then there are issues we still need more data to regarding the use of this in plasma exchange in routine management of patients with acute liver failure. Another liver assist devices which are available that includes Prometheus, Mars, and other devices have been shown to have any improvement in the outcome, and not even they don't also even help may in the as a bridge to transplant. So there are issues. We need more better devices to help in improving the outcomes. Now, coming to the most important treatment modality, that's a liver transplantation. And we know that across etiologies, liver transplantations are associated with good outcomes. This is transplant-free survival, and this is survival post-transplant. So there is a significant improvement in the survival post-transplant in such patients. So it's important when we talked about, yes, transplantation is the modality of treatment, but when not to consider transplantation, that's important. When the patient is clinically improving, you should not consider transplantation. When you've got 3 or more organ failures, especially circulatory failure, respiratory failure, you should not consider transplantation. You need to wait, watch, use prognostic models, start seeing them dynamically and see if my patient is improving, wait and watch. The patient has severe sepsis and even fungal infection. These are relative contraindications. You can treat such patients infection, and once the infection improves, you can consider them for transplantation. And those who got brain dead and those who have absent brainstem reflexes are absolute contraindications for liver transplant. So you should not consider transplantation in such patients. Coming to a word about pregnancy, yes, there is some data that suggests that patients with pregnancy, with those who got HEV, have more severe disease in pregnancy. But then overall, pregnancy is not a poor prognostic factor in patients with acute liver failure. And usually such patients would present as the pregnant women would present in the second and third trimester. Let's look at what is the outcome with different etiologies. What I showed you is that various causes. So hepatitis A and hepatitis E are associated with an survival of almost, this is transplant-free survival. That means they're going to improve medically with almost like 2/3 of patients with hepatitis A and E are going to improve. But rest of the etiologies C have a dismal prognosis, and only say 25% of them are able to improve without transplantation. So etiology does have a role in predicting the outcome also. So when we talk about etiology, then we've got some specific antivirals available for hepatitis B, and for drugs, you need to stop anti-tubercular drugs and then start them on medications as we talked about. What about ATTLF before I end the talk? Is ATTLF is associated with a very high mortality. And one of the most important factors which come out is that patients who've been started on empirical anti-tubercular drugs are those who are at risk factor. That means who didn't have tuberculosis but were given a trial of ATT. These patients are at risk of developing ATT-related ALF. And among these patients, the poor prognostic markers include a high bilirubin, high prothrombin time, and presence of advanced encephalopathy. And so, just to put in a nutshell, our protocol, what we do is we admit all such patients in ICU. You do a continuous monitoring, calculate their prognostic scores daily, give them a little bit of a head up tilt that helps in reducing the raised intracranial pressures, give them stress ulcer prophylaxis, target a MAP of almost like 60. Do elective ventilation whenever there is presence of any evidence of cellular edema or grade 3, grade 4 encephalopathy. We use the central venous line, do blood sugars 2 hourly, give prophylactic antibiotics and antifungals, and change as per the culture reports. And we trace the cultures daily to see if any new organism is growing. And this is something which is very important, and this can improve the outcome in your patient is to treat infection. That's very important. And we consider giving them Ryle's tube once we are able to place in a Ryle's tube. and then liver transplant counseling is done from the day of admission. So, in a nutshell, to put in, you have your patient in our ICU, you're monitoring him daily, you counsel them for transplantation, then you observe what is happening. His prognostic scores are improving. Yes, continue with the supportive care, consider him having a response and consider transplant delisting. But if he's not improving in his prognostic scores, think about referring to a center which has expertise of doing liver transplantation and you have a donor with you. And these patients can then be taken a call if you want to bridge them with the support devices or consider them for directly for transplantation. If they're worsening prognosis or prognostic markers are there, donors available, consider transplant. If no donors available, then you have no other option but to just consider them for support devices, take care of their raised ICT, take care of their infection, manage their electrolytes, prevent hypoglycemia, and support them and see how they fare. So now with this, I'd like to conclude the talk over here. Thank you for your listening. Thank you.
Thank you, sir, for a very enlightening talk and covering the basics very nicely, and then going on to transplant very nicely explained. I'm sure the students will love this. And just a couple of things I want to add for the students. One question they ask is about arterial ammonia. Is arterial ammonia better than venous ammonia? Which you showed that we should be doing arterial ammonia. So why is arterial ammonia important? The reason is that ammonia is mainly generated in the intestines, and from there via the portal vein it gets carried forward and into the IVC, into the heart, and then goes into the arterial circulation. And when it goes into the arterial circulation, it is detoxified into glutamine in the peripheral tissue. So the venous return has less ammonia. So the venous ammonia is less, and value is also a little variable. That's why arterial ammonia should be done, and it's always higher than the venous ammonia. Then coming to the second point about dialysis, RRT. This is one condition in which RRT definitely helps because the fluctuations in the intracranial pressure is much less as we remove the osmotic load. And this is another condition in which you can do dialysis for the ammonia itself. It's called a metabolic dialysis. Once the ammonia level goes beyond 150, you should be going ahead with CRT. It is definitely helpful and is advocated, and I think sir also showed a couple of slides on that. It reduces the cerebral edema and improves the prognosis. The third thing I want to say is, SGOT-PT greater than 1000. 95% of the times there are only three causes, and you can pinpoint the diagnosis. First is viral, second is drugs, and third is ischemia, in that order. So you have the diagnosis 95% of the times if the SGOT-PT is greater than 1000. Not to say that SGOT-PT greater than 1000 is liver failure, but if in liver failure you're getting that, then the diagnosis is amongst one of these three. Or even if you don't have liver failure, you can still have a SGOT-PT greater than 3000 and you can make the diagnosis with this. So because drug-induced liver injury is sometimes surreptitious. So you can think of that when the SGOT-PT is greater than 1000. The other point I want to make is about volume assessment. Sir said that these patients are relatively volume depleted. So the usual parameters like PPV and all those things don't hold true in acute liver failure because there is gross vasodilatation and other hemodynamic changes, and neither is PLR advocated because there is increased intracranial pressure. So it is a little dicey to assess the volume status. And probably you have to go with your inferior vena cava assessment or use the echo to look at small chambers and use ultrasound to see the B lines. So volume assessment in acute liver failure is a little difficult. Final point is about transplant. So sir told you that it's very difficult to sometimes judge whether the patient should be going for a transplant or not. Now the thing is one must realize that this is a very difficult situation, and if you can manage the patient medically, because if the patient comes out, he has a full life, complete recovery. While if you go for a liver transplant, the lifespan is shortened because they are on immunosuppressants and they succumb to complications, etc. So those are the few things, sir, I wanted to add. Anything you want to add to that, please, if you want to add to what I said.
For sure, I think I agree with your points, Dr. Tapesh, as you rightly said. But then in acute liver failure, I think it's a bit of a dilemma when to consider for transplant because when we talking about transplant, then we also need to also understand that we need to have a donor. And unfortunately, many a times the donors are not available, and our decision, if we delaying the transplant also leads to a poor outcome, then the patient may become untransplantable. So it is very important, and then such patients need to be so closely monitored. You're taking a call based on as it's like a continuous dynamic monitoring. It's like every 1 hour, 2 hour, any changes, you need to be very, very careful, and you need to make careful decisions based on that. So I think sometimes that's a very difficult decision when to consider a patient for transplantation. But then this is the only modality at present which has been shown to improve outcomes. And we are expecting the patient not going to recover, and then transplant is the treatment of choice, especially in patients with acute liver failure. Rest, I think you rightly pointed out regarding the fluid status, and then IVC filling, echocardiography, and all those things can be of very good use. And then these are very sick patients. I think those patients need to be managed on a multidisciplinary team where you got intensivist, you got an internal medicine person, you got a pathologist, you've got a transplant surgeon involved with it. So all of them need to take a call and then decide how best to manage, and decisions have to be done on continuous monitoring. So this is one group of patients where you need to take, and your decisions change depending upon how your reports are coming in, how the parameters are. So uncommon disease with a very poor outcome, and transplant can improve outcomes in such patients. But then, very important to say that medical management forms the backbone of treatment in such patients. A good medical management, taking care of simple little complications which are happening in terms of dyslipidemia, prevention of infections, can help improve the outcome in such patients. And this is what we need to do: is work as a team, monitor these patients continuously, and take care of them to improve the outcome.
Yeah. Just one thing I wanted to know from you, sir. Earlier, we never used to see dengue patients going into liver failure and getting transplanted. But in the recent couple of years, dengue is causing acute liver failure going into transplants. Are you getting those patients there, or what is your comment on that?
Yeah, so we are very commonly seeing is severe presentations of dengue in which liver involvement is also there. So then they have dengue and then liver involvement. So we're seeing severe cases of dengue, and then there are case reports of transplantation being done for them. But then we also need to keep in mind is that this is a sick group of patient who's got multi-organ involvement. So then the outcomes also would be affected. And then decision to do transplant in such a patient is not that easy when you're looking at cytopenias, low platelet counts, and then you expect more complications. We don't know what's happening to the disease itself. So those are little difficult situations, but then yes, there are case reports of transplantation being done in patients.
Right, sir. So thank you, sir. Thank you very much. It was wonderful to hear from you. Both of us having gone through the same hostels and the same lecture theaters to undergraduation and post-graduation, fellow Amazonian, sir, and now wonderfully a professor and doing so well. It's great to hear from you, sir. Thank you so much. And it will be up on our YouTube channel for the global audience, the global students to benefit from. Thank you so much, sir.
Thank you, Dr. Tapesh, for the kind invitation. Thank you.